This talk will be presented by Dr. Matthew Walker. I will be moderating this webinar. My name is Meena Lakshman, the Applications Marketing Manager here at Fujifilm Visual Sonics. Before we start, I am going to start with some housekeeping announcements. A recording of this webinar will be made available, and during this webinar, all lines will be muted. However, that doesn't stop you from engaging with us with questions. Please use the chat window at the right of your WebEx screen for your questions, and we will answer them at the very end of the presentation. That brings me to the duration of this presentation will be approximately 40 to 45 minutes with 10 to 15 minutes of questions. We will also provide you with some updates on new publications advancing research in atherosclerosis towards the very end. We'll also have some announcements for the upcoming year. Any of the webinars can be found on our Visual Sonics website. Now, it brings me great pleasure to introduce our speaker today, Dr. Matthew Walker III. And I would like to introduce him based on his current full-time faculty position at Vanderbilt University in the Department of Practice of Biotechnology, Bioengineering. He's heavily and actively involved with the academic commitments, and you can read more on our website. He also continues to service as an advisor and consultant with multiple companies as listed on the screen. I do no justice by just saying that statement, but there is a lot more that he's engaged and committed to the research community as a whole. Dr. Walker was trained as a mechanical and biomedical engineer with NASA Houston in Texas. Prior to his doctorate in cardiovascular biophysics and pharmacology from Tulane University School of Medicine, where his mentors include renowned cardiorenal researcher, Dr. Gabriel Navarre, and also the cardiovascular engineer at Tulane as well. We'd like to welcome Dr. Walker and thank him for his time as he will engage us in his journey using the Visual Sonics ultrasound system and give an ultrasound perspective on atherosclerosis and its biomarkers. Dr. Walker, we are going to share the presenter rights with you right now.
Oh. Okay, thank you. Thank you very much, Meena. I want to make sure I have access to control and laser pointer. Okay. Thanks for everyone joining in. I want to talk to you about a perspective that developed while I was with Merck, head of the cardiovascular ultrasound division at Merck, prior to coming back into academia. I'm going to present to you this concept of biomarker development in the context of three-dimensional ultrasound. Today's talk was centered around a publication review, a novel three-dimensional micro-ultrasound approach to automated measurement of carotid arterial plaque volume as a biomarker for experimental atherosclerosis. Now, we use this publication just as a backdrop because the real purpose of this study was to establish biomarkers for all kind of clinical disorders that might be where we might use imaging as a tracking point for pharmacological response therapy. Bullet point 2 speaks to the three-dimensional fiducial landmarks as biomarkers. So in this context, we say 3D fiducial landmarks, fiducial being mechanisms by which we can maintain the integrity of an imaging position throughout modalities, whether it's ultrasound or MRI. We want to be able to do that from the preclinical space all the way to the clinical space. And at Merck, we were trying to establish ways to develop measurable biomarkers linking to athero, diabetes, and cancer that might be used not just in athero, but all of our pharmacological profile programs associated with responses to therapy with these registration biomarkers. In this study, we use one scan, but we focus on 3 biomarkers. And the next bullet point for the overview is that we're going to talk about the drug development implications of this study, and we'll have at the end a discussion of atherosclerosis, diabetes, and cancer. This slide shows you atherosclerotic plaque in 2 dimensions, and traditionally with ultrasound, atherosclerotic plaque has been measured with 2-dimensional IMT. But if you look simply at this slide, you can see there's several biomarkers that we can interrogate using ultrasound that we can't do with 2-dimensional ultrasound. The primary one being the development and identification of the plaque volume. Plaque grows not just into the intimal area, but it also grows in 3 dimensions. It grows in length, circumference, and encroachment into the lumen. But the important thing about this fiducial landmark being at a branch point is that we not only can identify and track the plaque volume or area, we can also identify flow with Doppler ultrasound, and we can identify wall integrity or stiffness with M-mode ultrasound. So this study that I'm going to discuss with you today is the interrogation and the development of measurement tools around wall stiffness with M-mode ultrasound, wall volume of plaque with B-mode ultrasound, and Doppler measurements as the plaque progresses through 52 weeks in treatments of rodents. The beautiful thing about using Doppler ultrasound is that we don't necessarily know what is the first and best response to therapy for athero. Is it that we're trying to repair flow, or we're trying to repair plaque volume or encroachment? If we're treating for flow, then we need to know the degree to which we can measure flow. On the left-hand side here, we show in A, normal laminar flow at the innominate artery, the brachiocephalic, and the ascending aorta. We get distributed plaque disturbed flow, where you see a distribution of velocity flow profiles at the level of a blockade once we begin to develop plaque volume. These 2 positions, both the measurement of plaque volume and the measurement of Doppler flow in these regions, are measured with 1 scan. 1 scan, 3 modes. So that's B mode with the volume, and there's Doppler mode measurement here. We want to make sure we can measure with strong accuracy these 2 positions because we don't know which biomarker may be the strongest response to therapy. This slide shows you the advantage to using ultrasound imaging in your phase 2B development profile, which you're launching to phase 3. Early on, we may not know response to therapy into phase 2. That is when patients are enrolled at the number when we start treating disease. But the advantage of using ultrasound is that because we have fiducial landmarks, we can identify in the preclinical space exactly the response to therapy. Once we're able to develop the disease and start treatment in the preclinical stage, we get an early index on those compounds that more likely will fail that we didn't know would fail until later phase 2 in the early modality. But now we know early on in preclinical models that we're able to get an indication or an index of response to therapy in the preclinical space. And the beautiful piece about it is that because it's fiducial, we're able to use these same registrable ultrasound landmarks in the preclinical space that we use in the clinical space with humans. So ultrasound translates fiducially. Our landmarks for biomarker, being branch points, are strong biomarker indicators, and they also retain their therapeutic response value throughout phase 2 and phase 3 of clinical trials. So early on, you have experimentation, you have validation, standardization, and you have registration of a biomarker in the preclinical phase instead of the phase 2B phase as traditionally the case. We do not have to switch assays when using ultrasound. We can use the same assays, register those assays in the preclinical space, and save up to about $300 million prior to launch. Or we get the funneling effect going on in phase 1 instead of the funneling effect taking place in phase 2. So by way of introduction, studies of athero have encompassed a broad range of phenotypes, typically intermediate thickness, cross-sectional area of plaque, carotid stenosis severity, and plaque surface morphology have all been standard parts of identification of atherosclerotic plaque. But in none of those characterizations do they talk about the degree to which plaque grows in volume and there's an associated change in flow profiles in the same registration of disease. Additionally, measurement of carotid plaque has been useful for risk stratification evaluation of patient response to medical intervention, genetic research, and quantification effects of new therapies. Non-invasive image quantification of carotid atherosclerosis burden and progression is an important tool not just for discussion and diagnosing of biomarkers, but also in management of patients, stratifying patients, and figuring out which patients received which pharmaceutical response at what stage of disease. So stage gating disease has been an important part of image diagnosing before, but it has not been a part of preclinical assessment of disease or response to therapy until now. High-resolution real-time B-mode ultrasonography with Doppler flow imaging has emerged as a modality of choice for clinical imaging of carotid arteries. So because clinicians are comfortable with stage gating patients' disease sequelae with B-mode ultrasound, we think it would be not a far reach to make sure that we even strategize and categorize the disease response to therapy in the preclinical space, because adoption of the technology has already been done in the clinical space. Ultrasound B-mode, Doppler, and M-mode were all used to assess the functional changes in this particular study. And these M-mode, B-mode, and Doppler mode studies are all used in other studies as well in stratification of diseases. Once we're able to benchmark and categorize the degree to which we can quantify these biomarkers, these same biomarkers can be used in multiple disease states. Measurements of plaque volumes have been the potential to be more sensitive to changes than measurements of plaque area or intermediate thickness. That being said, plaque volume, because it grows in 3 dimensions, we have millimeters cubed instead of millimeters squared as an index of the sensitivity of plaque growth. So we get a much more sensitive response to the disease state and a much more sensitive response to therapy, because we're able to get more of the growth profile of the plaque over time. Our study allows for an accurate and reproducible segmentation of small advances in atheral wall thickening. Because you can get millimeters cubed, because we're volumetric, we get smaller indices of growth than you do with the IMT. The quantification is done to register with fiducial fidelity, structure, and function with sensitive characterization of therapies in a setting where each plaque and each animal serves as its own control. Prior to being able to use ultrasound, there were needed to be 30 animals at each time point to assess the degree of plaque. Whereas using ultrasound, because it's a longitudinal study, each animal and each plaque serves as its own control. So non-invasive imaging provides a much more powerful assessment statistically of the likelihood of response to disease, likelihood of response to therapy, and the risk and stage gating of disease states. The 3D micro-ultrasound data were compared to the 3D histological data for the corresponding vascular segment. This is done at the end of study to transfer comfort from histology, which is done prior to these studies, to allowing 3D ultrasound to be a strong surrogate for histology. Homozygous ApoE knockout mice were weaned at 3 weeks of age, and then they were transferred to the TD-88-137 Harlan-Tecklin diet for 49 weeks. Wild-type C57 black 6 knockout mice were fed a standard chow. Their genetic background wild-type. The standard chow diet ad-libitum them for 49 weeks. All mice were bred in a specific pathogen-free room with constant temperature and humidity. The experimental protocol was consistent with the federal guidelines and the Merck IACUC. Using 8 megahertz transducer, B-mode ultrasound can be used for measuring intermediate thickness. And I put that bullet point there because we want to be able to translate whatever we do in the preclinical state at the 30 to 40 megahertz range to the 8 megahertz transducer. And that's the only translation that changes the fiducial nature of the measurement between the preclinical state and the clinical state is the size and the range and penetration depth of the transducer from the preclinical animal model to the human model. The study protocol is simply that we remove the hair from the anterior chest wall of the animal using depilatory to gain direct skin contact, because an ultrasound gel needed to be administered for good transduction of ultrasound signal. The animals were maintained lightly anesthetized with isoflurane dose of 0.2 to 0.5 to 1.5% in oxygen. The Vivo 2100 visual sonic system was used, equipped with a 40 megahertz mechanical transducer. A right parasternal long axis view was used to capture the aorta at the branch point of the carotid and brachiocephalic. These branch points characterize a flow divider that serves as both a plaque-prone region and a strong landmark for serial studies. The important piece about this particular study is that the landmarks of branch points are conserved throughout the anatomical life of the rodent. These branch points allow us to register in frame the same position at multiple times. So when we come back and image second, third, up to fifth to sixth times, we're making sure that we're measuring the same fiducial places before, because branch points serve as strong fiducial landmarks. The benefit of studying carotid arterial plaque progression is that they happen to progress in regions of branching. And regions of branching not only show disease progression and response to therapy, but a strong fiducial place to register imaging over time. Mice were scanned regularly over time, and the images were digitally captured during the systolic phase of a single heartbeat in offline measurement. Given that accumulation of lipids and cholesterol and other components are first evident at branch point, these anatomical landmarks became excellent landmarks for disease and response to therapy, as stated earlier. Now, on your left-hand side, you see the Vivo 2100 system. The beautiful thing is that it has a very high throughput frequency. We were able to scan 210 mice per week. And the beautiful part about this is that the same imaging landmarks we use with this high throughput measurement can be used in the clinical space. We call it the future stethoscope. We got real-time measurements. We're able to do longitudinal studies. And we're able to look at measurements of physiological parameters other than just that which we're measuring, other than plaque volume and Doppler flow and wall stiffness. We're also able to get respiration, temperature, blood pressure, and ECG. And all of this information is translatable to humans, making it a beautiful assay in the preclinical space. This is the setup of the experimental design. An experimental setup simply shows you here that there is a motor generated. The sweep in the horizontal space allows you to get the three-dimensional assessment. So the three-dimensional sweeping and the penetration depth of the ultrasound beam gave the anatomy in XYZ planes. On the right-hand side, you'll see a schematic of how the animal is laid out, how ventilation and anesthesia is applied. The total scan time was 20 minutes to get the two fiducial registration landmarks. They were tethered to a heated platform. 20 to 60 megahertz Doppler probe was used, and parasternal scans of the carotid registration point was used at each and every time point. The important part about ultrasound imaging is that you have to be very clear, again, about anatomical registration points. Here I show you a postmortem casting of a mouse showing the fiducially registered anatomical points. Again, these fiducial registration points are good across imaging modalities, across clinical spaces, from the preclinical setting to the clinical setting. On the left-hand side here, we show the registration point 1. That's the branch point from the aortic artery to the carotid. The image here represents the transducer. Transducer is positioned in one position, and the horizontal sweep over that area gives us a three-dimensional voxel. On the right-hand side is the second registration point that we use in this study. Again, you see the branch point at the internal carotid artery and the brachial artery and the carotid separating. So these two registration points represent the anatomical landmarks that we use to identify the ultrasound images. In the next slide, I show you the ultrasound images that resulted from scanning in the prior anatomical positions shown. This is a three-dimensional Cartesian coordinate system voxel of volume pixel element, and you can see that it has depth and width and penetration length. And each one of these sections on the left-hand side and the right-hand side can be progressed through at 50 micron increments to see different components of the slicing that took place in the imaging of these sweeps with three-dimensional ultrasound. Here we see representation here of the carotid artery, left carotid artery, at a branch point from the aorta. Here we see the external and internal carotid as it branches from the common carotid. These are two idealized anatomical landmarks captured with 3D ultrasound. But the beautiful piece about this, again, is that what you're seeing here is a box, a three-dimensional box that is a volumetric voxel that is presented upon imaging at the anatomical landmarks identified earlier. This is the combination of anatomical representations, and these are the representative ultrasound images that resulted from scanning in these anatomical positions. And this was done at every measurement point along the 52-week study. Now, these represent all of the different axes that are aligned. So each one of these points A, B, C, and D represent planes through which the ultrasound image voxel was taken. Here you see the representative plane in the complete voxels, a three-dimensional registration of fiducial landmarks. The orthogonal registration and cross view is the characterization of Cartesian coordinate position as referenced anatomically. In channel B, we see an XY plane, and you see the beginning of plaque development here and here. The aorta is identified here, branch point here. The same image, just by manipulation of the voxel, no extra imaging, just by changing the rotation of the crosshairs in the voxel, you can see the YZ plane, brachial artery, carotid artery. And it is around this region that we draw our fiducial quantified segmentation markers for the external volume and the internal volume as we measure plaque progression over time. It is the YZ plane that is used for quantification of the images. And in panel D, you see the XZ plane. So depending on which plane you want to use to measure plaque progression, you're able to see them and you're able to quantify in each one of these landmark voxel frames. And these are rotated online and offline to identify positioning. Now, once we have identified the region of interest, we can use any one of those positions to start to do the segmentation, that is the quantification. Remember, biomarkers are not biomarkers unless they're measurable and reproducible over time. We have the aorta here, and we show you the representation of the outer wall, which is in red, and the inner volume, which is in yellow. The Vivo 2100 quantification system allows you to quantify each one of the sections. So these represent about 60 different measured segmentations across the length of the plaque as seen here. So again, let's look at this image here, and I can show you that we took a reference frame and encircled this cross point, and then we advanced the voxel a little more, and then encircled the next cross point, and we continued to do that until we had an entire length quantified with an outer and inner measurement. And that takes about 45 minutes to do that. But once you've done that, you've got a quantified voxel element within your entire biomarker range that represents the quantified image of interest. Once you have that, then you have an isolation point of an isosurface. The isosurface is the quantification that results from your segmented quantification. You see the common carotid with its associated markings in the oblique view, and we see the outer volumetric representation. The important piece to recognize here is that because we're able to look at multiple views, we're able to see growth in the encroachment region, which is the typical IMT direction. We're able to see growth in the length direction, and we're able to see circumferential growth of the plaque as well as it encroaches into the lumen. That gives us a three-dimensional quantification tool of plaque growth over time, and that's the value add. This gives us much more sensitivity of the true plaque growth biology and not just a representation of the silhouette of the plaque that's represented by IMT. Now that we've got the identification, then we want to compare the cross-sections with histology. Here we see each of these elements here that were segmented and quantified and recapitulated back into a complete isosurface. The beautiful piece about this is we can do slicings as small as 40 to 30 microns, depending on the positioning within the plaque that you want to see. And we'll compare that to histology. Of course, with histology, we're not able to maintain the integrity of that small of a slicing. But here below here, we show you the three-dimensional ultrasound image of a slicing of a common mouse. Mouse on the left, mouse on the right are the same mice. After euthanization and histology, an oil red O staining of the ApoE mouse at 52 weeks, we're able to get a comparison of the histology of the mouse in the common position measured at exactly 220 microns from the branch point of the aorta. And if we look at the outer area tracing, we see an outer area of 2.9 millimeters squared, inner area of 0.9, and the difference being 2.0. That's what the ultrasound quantification. Cross-sectional area of the same piece, same mouse, after euthanization and histology staining is a 2.4, 0.8 of the inner volume, and a difference of 1.9, showing you that there's strong correlation between ultrasound histological assessment and non-ultrasound standard histology of the same region of time. So results, we compared the arterial vessel wall volumes obtained with ultrasound with those of histology morphometrics using data from 6 animals at 52 weeks. The raw data used in comparison for outer wall volume and inner wall volume and their difference for each animal was measured just to validate the ultrasound imaging quantification measurement tool so we can establish it as a strong quantifiable biomarker. To further assess the degree of agreement between the animals, the correlation plots were developed, and a straight line of correlation indicates the degree to which there's agreement between histology and ultrasound. So in this slide, I show you the outer volume, inner volume, and volume difference. On the left-hand side, we can see the volume by ultrasound, and across the horizontal x-axis, we see the volume by histology for the outer volume, inner volume, and wall difference. And if you look at the correlation between the two, measurements between histology and ultrasound, we see a correlation. We see a strong linear correlation. But if you notice, if anything, the ultrasound volumetric measurement gives you an index that is slightly larger than histology. If you pile the histological sections together and give yourself a volume, you get a slight index, and that's owing to the real-life physiology and the pressure that's a part of the volumetric assessment and the live tissue. Likewise, we see a nice correlation of inner volume between histology, ultrasound, and with volume difference, a nice correlation as well. So discussion. This study demonstrates the ability of in vivo high-resolution ultrasound to accurately characterize atherosclerosis carotid artery of ApoE mice using much smaller voxels than described previously in this context in humans, reference from the documented publication. It was possible to reproducibly quantify lipid-rich and cell-rich components that fill mice carotid plaque volume in excellent agreement with measurements made by histology. There is less volumetric resolution, so the value to this is, of course, simply that we're measuring in millimeters cubed versus IMT, which is just an area representation of the silhouette of the plaque reflection. There's greater sensitivity to the changes, so the value in that is if we're testing 2 different drugs, we're able to see smaller changes in plaque volume than we would with IMT. It would take a stronger dosing and higher dosing to give you an index of change in plaque area than it would to give you a change in millimeters cubed volume. So we want the most sensitive biomarker as possible for consideration of discrimination between 2 compounds. Further, with multidimensional views of the vascular wall, we are not limited to in-plane tracking of the plaque in the direction of thickness only. as is the case with vascular IMT. Now, what are the drug development implications? So originally I talked about the fact that the atherosclerosis study was simply a primer or platform upon which we use to identify the degree to which we can track strong fiducial biomarkers across disease spectra. Because we're able to use B mode, Doppler mode, and M mode in this disease sequelae, we're able to establish the degree to which ultrasound can accurately give us indices of the status of components that relate to wall stiffness, M mode, to changes of flow profile associated with diseases, B mode, and changes in wall volume, B mode. So the Doppler mode gives us the flow changes. Now, we don't know whether therapeutic in disease will need us to identify changes in flow, depending on what the treatment is, or whether it needs to tell us a change in wall volume or change in vascular wall stiffness. But as a result of this study, we used the information that we developed in the patent that we wrote for wall motion, vascular wall stiffness, as a mechanism to parse the behaviors of a CETP inhibitor between Merck and a competitor. Micro-ultrasound was used in drug development to discriminate the off-target effects of the CETP inhibitor. Merck needed to make decisions as to whether the cardiovascular effects of the competitor's CET inhibitor was mechanistic or compound specific. In the competitor's compound, there was shown a slight elevation in blood pressure that led to cardiovascular events, but the response and the understanding of it was idiopathic. It was not clear whether it was a result of the competitor's compound or the CETP inhibitor as a mechanism in and of itself. Before we continued on with our CETP inhibitor program, we needed to understand better what the off-target effect was of our competitor's CET inhibitor. So the M-mode vascular wall assessment that was developed from this atherosclerosis study was used to parse and identify that there was a cardiovascular wall stiffness that led to systolic hypertension in the competitor's compound and allowed us to continue with ours because we were able to show that it was not mechanistic based, but it was compound based. So the infusion of this competitor compound, called torcetrapib, it showed that both the CETP transgenic knockout mouse and C57 black 6 wild type that there was a slight elevation in mean arterial pressure in these animals. But when you use the same treatment, the same compound using the anacetrapib, which is our CETP inhibitor, we did not show that there was an elevation in either vascular wall stiffness or mean arterial pressure. The mean arterial pressure that you see on the left-hand side that resulted from the treatment of the CET inhibitor torcetrapib resulted from a vascular wall stiffness in rodents that led to the systolic hypertension that we see that leads to mean arterial pressure increases. So the point here is development of biomarkers is important, but you never know where you might need to apply them. So it becomes a robust opportunity to look at responsive therapy in multiple different disease states. Diabetes and atherosclerosis have been shown to have similar sequelae, driven by inflammation, slowing blood flow dramatically accelerates atherosclerosis. The beautiful piece about identifying these biomarkers shown in the atherosclerosis study is that because diabetes worsens atherosclerosis, there's not an exact link that's been identified. The inflammation link is not clear. But the study and the resulting study of the therapeutic can be the same. That means identifying biomarkers with ultrasound can be important whether it's diabetes or atheros. Studies have shown that diabetes takes away the ability for the fast blood flow force to protect blood vessels. Again, blood flow associated with diabetes is no different than identifying and measuring blood flow associated with atherosclerosis. Biomarker development and measurement, again, arguing that it does so by interfering with ERK5 and signaling pathways. Molecules called advanced glycylation products, AGEs, produce at greater levels by patients with diabetes, and they interfere with ERK5. So the glycylation reactions cause the release of oxidative side products and hydrogen peroxide that drives a free radical and inflammation in disease states. Again, leading to accumulation of fatty products in the vascular wall. Although the mechanisms are distinct, the progression of diabetes-related atherosclerosis shares the same fiducial registration points for progression biomarkers, thus justifying ultrasound use in both ultrasound and diabetes. Now, let's move to cancer. Cancer, same way. In the recent series of studies have shown that they share molecular pathways. Both cancer and atherosclerosis share a common signaling pathway. The oxidative stress and the cellular damage that results from it have been implicated in a wide variety of disease processes. The toxic metabolites produced by cigarette smoking and increased dietary fat intake are implicated in both cancer and in atherosclerosis. And cell proliferation pathways, including G1S checkpoints, P53, P15, P16s, have been associated with plaque progression, stenosis, restenosis, after angioplasty in both plaque progression of athero and in metastatic progression of cancer. So ultrasound imaging will be a strong measurement and staging tool in evaluating the response of atherosclerotic plaques to these treatments, whether the common disease treatments or growth factor inhibitors, radiation treatments, anti-cancer treatments, statins, Vytorin. No matter what the treatment response profiles, the biomarker tracking and measurement tools are conserved across disease profiles. The important piece about the study I'm trying to share is that biomarker development is a useful strategy for coming up with mechanisms to interrogate different responses to therapy, no matter what your compound studies are. And with that said, I'll stop here and take any questions if there are any. Thank you.
Hi, Dr. Walker, thank you very much. That was a very comprehensive presentation on atherosclerosis in the context of diabetes and drug development particularly, and also to summarize its recent implications in oncology. While we're waiting for a couple more questions out here, there is one that has come along with regards to your 3D imaging acquisition. Now, generally, the 3D imaging acquisition is a very robust and a quick image acquisition workflow. In the context of the 3D segmentation analysis, how long did it take, and if you can perhaps elaborate on the segmentation that you used in making up this, in generating this particular assay?
Okay, the segmentation itself, that means quantifying and circling each voxel at each stage gate. I would use 60 different segments that were outlined for the carotid plaque progression, and each one of them took 40 minutes to do.
Okay, so it does answer the question, just a matter of time. But when it is acquired once, then the question is, once it's acquired, and this is just basically post-processing analysis, correct?
Yes, it's all post-processing analysis. Once you have the voxel image, then you can post-process and quantify any way you want. But the quantification voxel is embedded into the 2100 system.
Okay, the next question is with regards to your work, to your histology work, and I'm just looking at the slide number right here, number 22. I think that's an interesting presentation of findings right here on the screen. So there is correlation between the data that you acquired with the ultrasound and histology. My question here, or the question that we have here is, what is the thickness of the histological section? Was it a frozen or a formalin fixed? I suppose it's frozen because of the lipid-rich regions. And what was the thickness for the ultrasound section?
The ultrasound section was 60 microns. The thickness for the histology to maintain the integrity, because it was fixed frozen, was 180 microns. Any smaller than that, and we would use the integrity of that section of the histology.
Absolutely. So that brings up a very interesting point that in a 200 micron frozen section, histological section, there are chances that in that 200 microns there might be biomarkers that may be missed that could be potentially observed in an ultrasound section, correct?
That's correct, and that shows you another disadvantage of looking at just cross-sectional area, right? There says nothing about the thickness when we're looking at the cross-sectional area here. But when you're looking at the volume, that's the length on top of the cross-sectional area, you can actually see more of what the developmental biology is of that plaque. But you're missing it if you're not able to look at strategic sampling sizes. The smaller the sampling, the greater the sensitivity to quantification.
Absolutely, and this is where the 3D, and not just only the 3D, but your assay on 3D and the encroachment of the lumen, that fiducial marker is what helps understand the progression of this disease and test the development of drugs on this disease, correct?
Correct, yes.
Okay, so just a question on anesthesia. When these studies were performed, was anesthesia carried out with isoflurane and oxygen and not in air? Would you be able to comment on that?
Isoflurane plus oxygen, yes. That combination mixture, yes.
Absolutely. Okay. Is there a question? Is there a reason why that combination was chosen?
We wanted very light anesthesia because we did anesthesia at a plane of anesthesia that retained the physiological integrity. We wanted the animal as awake as possible because we were interested in maintaining heart rate at a near wake status.
Absolutely.
And that was the only way we could dial and tune the physiology to be as awake as possible because we're looking at dynamic markers as well. We did not want to reduce the physiological standard functioning of the heart. We wanted it as awake as possible.
Okay, and I suppose this reasoning has been discussed in your paper in 2009, correct?
Yes.
Okay. All right. So I think there were a few other questions, but I think these were the primary questions out here: the 3D segmentation and the benefits of 3D segmentation in a live mouse, also with multiple biomarkers, including 3D, B mode, M mode, and Doppler, to evaluate the progression of atherosclerosis was very beneficial in educating us as to how to assess this disease in the context of drug development. Thank you, Dr. Walker. What we're going to move on right now is some advancements in the field of atherosclerosis, particularly with the use of ultrasound. And one of the, as Dr. Walker was mentioning, the use of flow velocities to study the effect of shear stress. It was presented recently in this publication on rabbit carotids. So keeping along the lines of the same anatomical marker, anatomical landmark, which is the carotid, here we see wall thickness and flow velocity were being used in the study of shear stress. Also, plaque can be another landmark suspected for plaque is the aortic arch. For those who have understood how Dr. Walker showed you the 3D segmentation, this can be also done at the aortic arch. An example is shown right here on the screen, showing the red regions to be plaque areas and the aortic arch segmented in blue. Another example in the next slide is looking at other anatomical landmarks suspected for occlusion, like the coronary and the aortic root. Shown out here on the left side is the coronary. This high definition image is acquired on the Vivo 3100, right here on the left side. And then looking at the level of the aortic root for any deposition. What you're seeing out here is a normal structure, and however, one can imagine that area being imaged for occlusion. Another Another paper worth mentioning is looking at the vasa vasorum, also here in the carotid, presented in this paper in a transgenic atherosclerosis model. This was a publication in 2011 where they used microbubbles against a VEGF DSPR targeted contrast bubble, and it's presented again in the carotid. If that is of interest to you in terms of molecular imaging in the carotid, you can also look at a list of imaging markers that's on our website. The web address is right here at the very bottom of this slide. And you can have a look at it and let us know if there are any publications you would like to see with regards to the molecular marker of interest. That moves on to the next slide on vessel wall tracking. Dr. Walker talked about the intima media thickness. In this paper that was published last year, and also was talked about in our webinar series, where they looked at the intimal hyperplasia and quantified it using vessel wall tracking algorithms that is available on the Vivo Ultra. Okay, and that brings us to the end of this webinar. I would like to thank our speaker today for taking the time and educating us on how the ultrasound, high-frequency ultrasound has shaped high-resolution in vivo imaging. Dr. Walker has given us a great presentation and also is our last speaker for the 2014 theme on shaping high-resolution in vivo imaging. What to expect, we will be bringing topics on bringing discoveries to patients in our 2015 series. At this point, I'd like to thank all of our Vivo ambassadors and speakers on our webinar series for educating and sharing their research findings and their experiences using high-frequency ultrasound on our Vivo imaging solutions. Also, congratulations to the 2014 Vivo Young Investigators Award, awardees, I should say. The awardees span from cancer researchers to cardiovascular and vascular imaging researchers. We would like to congratulate them, and all there's call for abstracts for the 2015 competitions. Keep in mind that announcements will be made through email, so check your inbox. If you have comments or feedback or would like to hear more on certain topics, you have the customer feedback web the link. Please click on it and provide us your feedback or any topics that you would like us to cover for 2015. At this time, I'd like to thank you all, the audience, for making this a successful webinar series for 2014. And I'd like to thank Dr. Walker for a great presentation and invite him to be part of the Vivo Ambassador community. Thank you all.